It is a very great honor to interact with this group. It was Catherine having given away some of my secrets. This is the 50th anniversary of my entering graduate school, of beginning graduate school. Now you may wonder, is he still standing? What's he doing up here? Well, with the help of a new knee a few weeks ago, I'm managing to muddle through. But, so I have had a long career in psychology. I've done a lot of different things in psychology, and every day to me has been exciting. I have never truly been bored a single day in my life. I've been stressed and overwhelmed and had too much work to do and too many demands, like all of us, but something exciting happened every day. And to me, that is really being blessed. I'm blessed to be a psychologist and to have a rich and rewarding career. And I'm very much excited to come and speak with you today. Is that better? All right. So I also want to say that much of my career, well, I've been seen patients all my life, a fee-for-service kind of practice. The major part of what I have done, as Catherine pointed out, has been to focus on the development of new psychological services, try to come up with new treatments to add to our arsenal, to make treatments better, to compare them to medications, show that we have some good alternatives to medications. And some of you are familiar with that work. But the fact is that unless what we do in our clinics and research clinics and laboratories really becomes useful to the people out on the front lines who are confronting the difficulties that they see every day with complex, difficult patients, then obviously what we do is not worth much. So again, one of the things that's been very gratifying is at least some people have certainly found some of the things we do useful. And what I'm going to do today is just give you an overview, it would be a relatively brief overview, of the progress we've made from my point of view over the previous decades, where we are today, some of the good news, some of the exciting things that have happened. Catherine has mentioned some of these trends already. Also some of the sobering context in which we operate today, and end with kind of a few future trends, again, all of which from my own perspective. So, with a nod to my Massachusetts delegation and our Boston Red Sox, let me begin. Oh, and I have you can tell I'm technically challenged, right? Here we go, okay. So, how far have we come? Now remember, I go back a long way. So I go back to the time when the prevailing point of view in terms of our therapeutic services was reflected in the conclusions of Hans Eysenck, who some of you who are more in my age range may remember. And this point of view was very prevalent in the 50s and 60s from those people looking for some more objective indicators of the effectiveness of therapy. Now, 50 years has passed, and look at this quote that not all of you may have seen because it appeared in the journal Nature, which is more of a hard science journal. It's kind of the sister journal of science, more for the European audience. Studies to enhance, this is an editorial, there's a therapy deficit. Studies to enhance the psychological treatments are scandalously under-supported and have a chance to make a substantial difference. In fact, what they've been talking about, of course, is the recent trend, not only in mental health, but across the healthcare professions and beyond, to almost any kind of practice venue, professional venue, to emphasize evidence-based practices. And this is the definition that everybody has seen, I'm sure, that was originated by David Sackett, published by the Institute of Medicine in 2001, and with some kind of adaptation to make it more relevant to us, adopted by the APA in the statement in 2006. So this is policy for the APA now. And this has driven a lot of the policy, as you well know, at both the state and federal level since that time. How do we match up to this policy? I'm still on the good news part. We do very well. This is just a sampling of studies. These kinds of studies are the studies that influence policymakers. They happen to have been studies, I've just chosen sort of a random selection of them over the past decade or so, that have been published in two of the journals where policy is often made. And that's the New England Journal of Medicine and JAMA, Journal of the American Medical Association. Kind of too bad more policy isn't made than our own American psychologists. But the fact is that these are very influential journals. And in every one of these cases and more, you will see that there are clinical trials looking at the efficacy of psychological interventions, psychological therapies, and finding that the psychological treatment, and that's the PT on this slide, the psychological treatment was at least as good and often better than the first choice medication for whatever the problem was. And study after study. And the treatments, and I'm not going to spend a lot of time on this because I'm going to move on to more of the future, but the treatments are actually a very diverse lot of treatments. They come from different theoretical orientations. For example, one of the most powerful treatments that many of you use, I'm sure, in your practices is called motivational interviewing or motivational enhancement therapy. It's a very useful and proven evidence-based procedure for engaging the patient more thoroughly in therapy. And by the way, that's true whether it's a more mental health condition or in the more physical side of healthcare. And it's right out of Rogers. It's a Rogerian procedure where they've taken the strategies that highlight some of the Rogerian contributions and put them together in a very, very useful procedure. We routinely use it now in our clinic as part of our armamentarium. Interpersonal systems therapy. In our own therapy we're developing, which is, we think, maybe possibly the next step for emotional disorders. We incorporate some psychodynamic concepts. So the schools of therapy, in my view, as I've been saying for decades, I think are beginning to be less important as we put our emphasis on what kinds of psychological procedures are going to work best for us with the patient sitting in front of us, and we draw on that evidence from where we may. This has led to policy changes. There's no question that these results have had an impact. This is just something I came across in the past week or so. I'm sure our folks in the practice directorate are well familiar with it since they've been working closely with the WHO in recent years, but it's the mental health gap recommendations, and you can just look at, I just culled a few of them out of these recommendations that come out of WHO for treating acute traumatic stress. Doesn't do me any good to point here, does it? For treating acute traumatic stress symptoms, you can use some psychological treatments. In this case, they talk about cognitive behavioral. But benzodiazepines should not be offered. Antidepressants should not be offered. And this is true for both adults and children. These are policy statements from the WHO. For insomnia, which I'll talk about in a second, look just below that. They recommend a number of psychological interventions with which you're all familiar, calming techniques, relaxation, sleep hygiene, etc. Point out that drugs, once again, should not be offered in the treatment of these conditions. Those are pretty powerful statements. We also have this consistent finding about the services that we offer. This is a meta-analysis of 33 studies, 33 different studies, showing that with a ratio of 3 to 1, patients would much rather have a psychotherapeutic intervention than to take a pill. We thought we would see this a lot in our clinic, but we thought, well, it must be a selection bias. You know, they come into our clinic, and because we had psychiatrists in our clinic, we always have all along. And once in a while, we'd get a patient and say, you know, just give me a pill and send me on my way. I don't want to talk about it. You know, I just want something to make me feel better. But the overwhelming number of people would say, for whatever reason, no, I want to learn something. They'd often conceptualize it as like a course. You know, I want to learn more about how to deal with my issues. They prefer psychological treatments. And furthermore, because they prefer it, there's also data showing that they will get more benefit from a treatment they prefer. It's another common factor to add to the list of common factors across treatment. They will benefit more substantially from treatments they prefer. What are the reasons for this successful enhancement of our psychological procedures? We understand a lot more about what we're treating. Everybody in graduate school had courses in psychotherapy, courses in psychopathology. Well, knowledge has advanced considerably. We understand a lot more about what we're treating. We understand not only the psychological factors that make up some of the conditions and make them differ one from the other, but increasingly we're finding out about the brain circuits that underlie this psychopathology. And to say right at the outset, before I go any further, about the fact that our psychological treatments change these brain functions, sometimes more efficiently than medications do, in different ways, obviously. They clearly change brain function. Also because we've improved our methodology, and because healthcare systems and governments are obviously promoting, as Catherine pointed out, some of these more evidence-based procedures. And before going to some of the more sobering context, let me just make a few comments about the international scene, since not everybody may be as familiar with what's going on in the rest of the world and the more developed part of the world. So to take, for example, the UK. The UK, through its National Health Service, has spent over $1 billion disseminating psychological interventions, psychotherapeutic interventions, particularly for anxiety, depression, throughout their primary care system. They have a system in the national health system that's like catchment areas. And their goal is to have these treatments. It's called the Increasing Access to Psychological Therapies, IAPT. Their goal is to have these treatments delivered by competent practitioners throughout the country. That began about 6 or 8 years ago, and through every administration, both conservative and in the conservative administrations in the UK, they have sustained this effort because they have seen results. And guess what it's done to psychologists? It shouldn't be any secret. The government all of a sudden, in their National Health Service, realized, hey, wait a minute, we need more people to deliver these treatments, people who can be competent in delivering these treatments. They went to all of the clinical psychology programs, which, by the way, are supported by the National Health Service to turn out clinical psychologists, so very different from this country, obviously. They went to the programs and said, we need more clinical psychologists. we need at least 10% more each year for like the next number of years, and gave them the funds to support that kind of effort. The other thing that happened is that the salaries of psychologists in the National Health Service crept up to the point where they were overlapping strongly with what they call the medics in that system. So again, supply and demand. Now, did this just happen? Did somebody in the National Health Service say, oh, those are interesting data. Gee, maybe we should cut out a lot of the meds we give and move more in this direction? Of course not. Of course not. Let me tell you the story of what happened very briefly. There was a prominent psychologist in the UK who was, at that time, professor of psychology at the Institute of Psychiatry, which is kind of the leading post in the UK. And at a formal awards dinner, where he was getting an award, he happened to sit down next to a very prominent economist who was also getting an award. They hit it off. Personally, they began talking, and to make a very long story short, this economist was a member of parliament. And he asked questions about cost effectiveness of our procedures. We had the data. We have the data here. We had the data on cost effectiveness. He bought it hook, line, and sinker, because it was true. And he became, then, a primary advocate in Parliament and with the administration for this to happen back in around 2006 to 2008. He developed the cost effectiveness data so it was presentable, understandable, brought it to Parliament, brought it to 11 Downing Street, which I understand is the financial hub, and ultimately to 10 Downing Street, and they sold it. It was advocacy that made it happen. It was cultivating this member of Parliament and not letting it go, and then fighting every battle that came up, every rear action guard. You can imagine some of the opposition that arose to putting a much greater emphasis on more psychological interventions. It was also assisted, quite frankly, in the UK by a less, let's say, less of an emphasis on medical treatments and more of a realization that there's some real downsides to the drug treatments. So there is more of that in the UK, as some of you may know. There's another country, just to mention briefly, Australia. They have an initiative in Australia they passed a few years ago called Better Access, similar kind of thing. And what they mean is better access to psychological interventions. And, long story, but the bottom line is that what has it meant for the salaries of psychologists who are getting paid under this system? Well, for fully trained clinical psychologists in Australia, the fee they're now getting, it's a fee-for-service kind of system, much like ours in that sense, although it's, again, more organized along national lines. For psychologists, $147, Aussie dollars, an hour. They have something in Australia that roughly translates as a junior psychologist, who's not as well-trained, more master's level type. The fee for them is $97, and the fee for social workers is $87. Why? Because these are called psychological therapies. Who's best qualified to deliver psychological therapies? There is a marketing advantage there. I suggested 20 years ago that we label some of what we do as psychological treatments. People fussed about it a little bit, particularly the non-psychologists. But the fact is that in some of these places, it's working. So that's some of the context. And the question, of course, is, with the kind of advocacy in our much more complex, emerging healthcare system, with all of its, the pitfalls as we begin to develop these things, can we advocate as effectively? It's going to be much harder here. And everything Catherine said about the diversity of these kinds of efforts in terms of advocacy we're going to have to undertake, but nothing will happen unless we do it. We can be sure of that. Nothing will happen unless we do it. So, in our country, and here's the more sobering news, the trends aren't good in terms of the sort of balance of the use of medications for various mental health issues compared to psychotherapy. This is a slide taken from some very distinguished epidemiologists who tracked things over decades, and 2005 is the most recent. It takes a while to compile all these data. And you can see the marketing efforts of Big Pharma have been very successful. But what about psychotherapy? Not so much. In fact, this is a definition of psychotherapy for this study nobody else would use. It's anything more than 20 minutes, basically. You know, of somebody spending more than 20 minutes with a person, often in a primary care office. So it would include a primary care physician or somebody else in the primary care physician's office spending more than 20 minutes with a person to discuss, you know, their stress or their depression, something. So it's very liberal definition. And you can see it's going down. To me, this is one of the most alarming trends. This is the increasing use of antipsychotic medication for anxiety disorders. And this is as a first-line treatment. So this is not, oh, nothing else worked, you know, let's give them an antipsychotic. The first-line treatment, despite the fact there's no indication whatsoever for these very powerful drugs, and there's all kinds of downside, all kinds of, you know, very dangerous side effects. Here's some of the information on it. As you can see, I understand you'll be getting these slides, and I'm happy for you to have them so you can look at some of these things more closely. Notice just, though, that the largest increase for antipsychotic meds is among new outpatients. And particularly, in something that wounds me to the core, for panic disorder. I mean, you know, we have effective treatments for panic disorder, far more effective than some of these meds. So that's obviously concerning. Why is this discrepancy in the States, up until recently at least? Well, it's no secret. Heavy marketing and also the readily available nature of meds. So the question becomes, how can we overcome this? How can we begin to get our psychological interventions, our psychotherapeutic interventions, kind of more out there? Just as another indication of the demand, the pent-up demand that exists for some of the things we do. Here's some information from some of my colleagues working in the area of sleep disorders. Whoop. So the American Academy of Sleep Medicine, some years ago in 2008, just a little bit before that, looking at the literature, decided that far and away, the first-line treatment for all kinds of insomnia, primary or secondary, would be the psychological intervention. Many of you are familiar with it. I'm sure you know it in your practice. If you don't, it should be in every psychologist's armamentarium. 3 or 4 sessions, sleep hygiene, some calming techniques, etc. Nothing magical about it, but you know, it obviously has to be administered in the context of understanding the whole patient and how much depression plays a role and the like. But what do you see? What does the public see? They see a green butterfly coming down and sitting on their shoulder and putting them right to sleep. So guess what? Sleep medications are one of the largest selling, most profitable drugs in this country. By the way, there's only 2 countries in the world that allow direct-to-consumer advertising, as you may know, for psychotropic drugs, or any drugs for that matter. One of them obviously is the United States. The other is New Zealand for some reason. The only places where you can get this direct-to-consumer advertising, see the pull demand that it creates from patients going and say, I want that green butterfly drug. And yet, this Academy of Sleep Medicine says this is the first-line treatment. We're not even going to accredit a clinic as a sleep medicine clinic unless you have someone in there who can deliver these psychological interventions. And yet, by last time I looked on the website before it came down, they still only had 210 people who were accredited for 1,600 clinics. So what are they doing with accreditation? I don't know. They're probably getting around it somehow. Why is this issue of disseminating our treatments so difficult? Other than the obvious fact is we don't have the resources of people like Big Pharma, to go out and sell their wares. Well, dissemination and implementation, spreading knowledge, is just a very, very difficult thing to do in principle. It's not just us. Everybody has difficulties. And my favorite example, because it's so stark, is you all have probably heard the very true statement that the most dangerous place in your community is the hospital. It's where you pick up nasty infections. Again, I just had a new knee put in 6 weeks ago. That was 50% of what they talked about. And they sold their services in Boston, this is a very good hospital in Boston, on the fact that their infection rate was one of the lowest in the city. When we asked about going to a rehab place to get quicker attention to rehabbing the knee, they said, oh no, don't go there. There's a greater danger of infection. Go home. Go home and do your physical therapy and stay consistent with it. And that's a message that's, there's a whole profession now in medicine, infection control people. What's the biggest, not the only by far, what's the biggest source of infections in hospitals? It's the staff not washing their hands. Still. Now, washing hands these days means using the disinfectant gel. So you may have heard recommendations if you've been in the hospital recently. It's up to you to ask the person who comes in, did you wash your hands? Have you gotten some of that information? Well, you can see some of the data, the number of people who die from infections in the hospital, and yet, before this is information from Atul Gawande, who's been written some really interesting things on healthcare policies. So before this was introduced, the rates of hand washing were 33 to 50%. So they tried very hard to say, we should be able to turn this around. Nobody disagrees with this. This is not controversial. There's no theoretical fights over should I wash my hands or not. We should be able to disseminate hand washing to these hospitals. So they did. So they brought in teams of people to see if they could improve these rates of hand washing. And they did all kinds of surveys. They followed people all around. They did the obvious thing, first thing, just ask people, could you wash your hands more before you go into a room and see a patient? Well, here's what they found in terms of the reasons why healthcare personnel do not always wash their hands. Inconvenient, not enough time. They didn't like the alcohol content. It irritated their skin, so then they put some aloe in. Then they said, well, the aloe stinks. So they had to take out the aloe. Some people said, well, yeah, I don't know about this stuff. I think it might affect my fertility, etc. So after massive efforts to try to increase hand washing, look, the rates improved, but the highest they got was like 75%. That was not high enough to cut the rate of infections. They have to get up to around 90%. To cut the rate of infections. Now, these efforts are still going on. I don't mean to denigrate, but people are working very hard in hospitals to try and deal with this. But if you can't disseminate hand washing easily, what are we faced with? So, well, when we come to our efforts, I'm just going to now give you a brief kind of 30,000-foot flyover of where we are with some of our efforts in the more psychological treatment. There are roughly two broad strategies. One is this intensive community training model, and if you're in the VA system, as I'll say in a minute, you've seen this in action, where you're basically spending a lot of money to convey to practitioners and train them in specific kinds of new psychological procedures to get them up to a level of competence. The other one is a very different kind of model, and that's the public health model. And as you know, the kind of philosophy of public health is how can you influence the greatest number of people least expensively? You know, what kind of procedures can you introduce that will reach and impact people, but at a cost that is more affordable? So these are the two general strategies. And with that in mind, let's deal with the intensive strategy first. So these are the data from the National Health Service in the UK I was telling you about. And they utilize this kind of strategy of intensively training people. And again, their notion was, much as we're looking at in this country, of integrating them directly into these primary care catchment areas. But the VA may be a better example, a bit closer to home, perhaps to some people who are associated with the VA. This is currently the largest healthcare system in the United States. We all hope the Affordable Care Act will change that fact. They have also spent over $1 billion already, and by the way, over a period of 5 years, up until last fall, this program, as many of you know, was headed by a psychologist, Tony Zeiss, just recently retired. And so there's been a massive hiring activity in the VA. I think 75% of it was psychologists. In terms of dissemination, up through 2010, which takes them a while to pull these data all together, they had spent a great deal of money trying to obviously focus on treatments that would be useful for the tragedy of our returning vets from the wars in the Middle East, Iraq, and Afghanistan. They've since have expanded this to other kinds of treatments, interpersonal therapy, and others that were focused on depression and like. But they began with this. And the results have now come in. This is an article that was actually, even though it says don't duplicate this slide, the study did come out, I think, in JCCP, so some of you may have seen it, where they looked at the effects of this. And the bottom line is the effects were pretty good. It looks like they can do this. What they didn't say was how bloody hard it was to do it. It was very, very difficult to do. But they did, as the title indicates, make it work. They trained over 1,000 clinicians, most of them psychologists. A few dropped. And in terms of some of the treatment outcomes for the patients they would treat in this kind of open clinical trial, you can see that their scores on a common PTSD questionnaire, as well as a common depression scale, did in fact look very good. So that has been, by and large, a successful effort, but the VA obviously is a closed system, you know, and that makes it a little bit more like the National Health Service in the UK. It is not our kind of, you know, more generally diverse and open system that's very much in transition at this point in time. But there are other examples where this kind of training has worked, but it is expensive. It's expensive and it's labor intensive. But some of you may be associated with the National Child Traumatic Stress Network, where they have a lot of learning collaboratives and ways to try and get the latest treatments out to traumatized children. The procedures that you have to engage in to make these kinds of efforts, intensive efforts, successful are listed here. You have to do the kind of assessments. What are the barriers to making it work? What kind of training structures should you use? You need both didactic training, but you also have to have the hands-on supervision, you know, to bring people up to a level of competence. You have to make sure outcomes are collected, and again, that's an emerging trend in any healthcare system, as Catherine also said. And then finally, you have to ensure that there's some sustainability to your efforts. And how do you do that? The typical way is a train-the-trainer model. So you take people in these variety of settings and try to train them to a high level of competence with the notion that they would then take over with some administrative support. So this is a work in progress with some interesting kind of results. We've also been experimenting with disseminating some of our procedures, in this case, some treatments for panic disorder in adolescents, out to practitioners in the community who are interested in learning these. And this is some preliminary results from a recently submitted manuscript. And one of the things we're interested in is we know just having people come and attend the workshop doesn't really do much, doesn't really change behavior, you know, in new workshops. Entertaining and all that, but it typically doesn't change practice. What about the interactive online training, where it's kind of a web-based interactive training, often with vignettes the therapists work through in their own time. And then we added a third condition. We had the text only, which is really just giving them kind of the outlines of the treatment. Then we have this interactive online training. Then we had a third condition where we created a learning community among some of the practitioners interested in getting this training, and built it on Twitter accounts. And what you can see is, all I wanted to show you here, is that the therapists were much more satisfied with the kind of interactive training procedures using some of the modern day technology, which we all know will be a great part of things. And furthermore, they were much more, the Twitter account seemed to contribute something substantially to make them more proficient. They talked about it among themselves, you know, problem solved and things like that. So that's a little taste of things to come. So that's kind of the intensive training model. What about the more public health model? What's happening in those realms? Well, there are efforts in those areas with more psychological interventions. There was a big initiative that recently took place in the West Coast, 4 different cities up and down the West Coast, in 17 primary care settings with over 1,000 patients. And this was to deal with people with various anxiety disorders, severe enough that they would meet criteria for diagnosis, and it brought them into their primary care office. So it's kind of an interesting study because, once again, it reflects, you know, what can be done in these integrated settings? You know, how can this work? Well, what they would do is, for most of the patients coming into these primary care settings, they would give them a kind of general screen, find out the ones who look like they, you know, passed the cutoff point with more severe anxiety, do a little more work and determine if they really presented with an anxiety disorder. And then they tried out a web-based, in this case, a web-based CBT treatment, web-based interactive CBT treatment, that was supervised by anxiety clinical specialists, mostly nurses, a few social workers, all reporting to a psychologist in the primary care settings. And the psychologist would be the troubleshooter and the supervisor. And in this kind of what we call effectiveness trial, patients could choose medication if they wanted to. It turns out about 9% just chose meds. They didn't want any part of the computer program. But again, a very small percentage. Most people wanted the psychological kind of intervention. A few more chose both, but the majority of them chose the psychological intervention. And this was an interesting model. Once again, compared to usual care in these primary care settings, it showed a good, robust effect at a relatively small cost. The public health model is perhaps taken to its ultimate extreme in some underdeveloped countries, often sponsored by WHO or other organizations that are very interested in this kind of dissemination. And here you can see a very rudimentary intervention. It's called cognitive behavioral, but it would pretty much be common sense treatment for mothers with depression in rural Pakistan. This is postpartum kind of depression. And here, it's almost like the old Chinese concept of the barefoot doctors you heard about in the 70s. But it's the community workers that have some rudimentary kinds of instruction from some mental health professionals in central locations who are then sent back to their village or their area to deal with this issue. And what you can see again is that when you compare this to the usual kind of care they get, which is not much, you see a good, solid public health kind of impact. We're just currently dealing with the country of Colombia. Colombia, as you may know, just briefly, is ending a very long civil war. And one of the most horrible, traumatic kinds of events in the country of Colombia was kidnapping, because this was the weapon the rebels used, but also the right-wing militias, used most often to get their territory or achieve their aims, and the population was just tens of thousands of people kidnapped, months, years at a time. You may have heard about some of them. Now that's coming to an end. They finally have pretty much, the war has pretty much ended, and the government has decided they need to do something about the trauma that exists. And so they're creating a massive kind of effort, and they're funding it. We happen to be consulting to it, to do something similar to this. There are, like any country, a lot of different ethnic groups, different languages, different cultures, and the notion being, how can these things be adapted most effectively to the culture? And by creating these community workers, some rudimentary training, some psychologists in the background, funded by the government, the notion will be that maybe we can get out there and do at least some good. We'll see. So, present status, before I get to maybe a few sort of predictions. We do have some effective psychological treatments. Won't be any secret to you if you've heard anything or seen anything I've written recently, that we overshot in terms of all these massive numbers of different psychological manuals. In drugs, they call it the copycat drug. We can say the same thing in our field. There's there's 15, 20 different treatments for panic disorder. They're all pretty much the same. And the protocols are still relatively complex. Once again, if you can't disseminate hand washing, how can you disseminate these protocols? There's that notion. So here are some current trends. Now you're getting even more into my view of the world. One is transdiagnostic treatments that identify core psychological principles of change that can then be brought into primary care settings, greatly simplifying it. The second one, already mentioned again by Catherine, advances in telehealth. Another one, the emerging role of specialty clinics. We wrote something that just came out in AP about this. Specialty clinics are not going away. In fact, there may be a greater need than ever for specialty clinics. And finally, can we do our own direct-to-consumer advertising and create some pull demand, much like the green butterfly? Should we be doing more of that? First of all, in transdiagnostic treatments, we have, what we're working on right now, which is very exciting to us, is a protocol which again identifies 5 core psychological principles that address the underlying features of all emotional disorders. There's anxiety disorders, depression, closely related somatic symptom disorders, dissociative disorders, and the like. And what we're now targeting, based on a lot of information developed by our personality psychologist and experimental psychopathologist over the last decade, what we are now targeting is rather than symptom clusters making up DSM disorders, we're targeting temperament directly. In this case, neuroticism, which is the fundamental building block of all emotional disorders. Now, you might say, but we learned in school that temperament's a stable, enduring trait. And turns out, not so much. Some of these temperaments are more malleable than it may seem. And so the question we're asking now is, can we influence that? You can see in yellow the kinds of modules we're using. There's a lot of these derived from the emerging emotion science literature. So kind of a mindful awareness of your emotional life. Most of our patients don't have that. They avoid their emotional life. Some cognitive appraisal, which is a very powerful intervention that does, once again, change brain function. We deal with the kind of emotional avoidance that these people experience. Introduce some procedures that help them tolerate the kind of physiological manifestations of intense emotions. And then do what we call emotion exposure. So to take someone who has, for example, agoraphobia, do we worry about exposing them to the mall or to public transportation? Not so much now. We're now more concerned with exposing them to their internal intense emotion of fear and anxiety. And those, my colleagues in the audience with more psychodynamic predilections will say, that sounds familiar. But we're using that as kind of a key process. So a mindful, increased awareness of one's emotional life and an increasing ability to stop avoiding one's intense emotional life, being exposed to it, come up with some new ways of dealing with it. Turns out that's important across every emotional disorder, characterized by, again, neuroticism, negative affect. So that's one thing we're doing. So far, so good. We created you may be aware, NIMH is creating a very biologically based, they call it the RDoC, where they're more interested in brain circuits. These brain circuits are important, but we're creating our own kind of psychological RDoC, if you like. So this is a new questionnaire we developed, which we think, it looks like an MMPI, but it sort of samples all of the main features of all emotional disorders and guides treatment. So it eliminates the issues of comorbidity, if it works. We haven't got the definitive data yet. You don't have to pay attention to comorbidity. You don't have to pay attention to establishing what's the principal diagnosis. Treat this kind of neuroticism. We'll see. So far, the results look good. Take it with a grain of salt, preliminary data. Other trends. My colleagues in Boston at the VA have said, can we, taking a more public health model again, can we put some of these treatments totally online? Since they have such difficulty reaching a lot of the vets once they come back and they're discharged. And in this case, they're looking at people with both the post-trauma symptoms who are also abusing substances, particularly alcohol. The advantages of putting something entirely on the web are obvious. Here was a design. Either immediate treatment, that's IIG, or delayed treatment. Anonymous web-based treatment. It's immediate or delayed. Recruitment. Facebook. What else? They saw several advantages to Facebook, and they were able to get people into treatment for as little as $30 a person. Now, Obviously, that's not something that would happen in a private office. But for the VA, they're very interested in can they reach these people for a small amount of money. Sample Facebook ads. Notice the number of people who viewed them, which of course you can track. They've got it down to the money per click. Here's the reach across the country. No one's left home. No one's left their office. And the results, the preliminary results, look very, very interesting. PTSD symptom changes, etc. So that's clearly another trend which we're going to be looking at. Who devises these programs? Psychologists. Who would supervise them? Psychologists, and oversee their implementation. I don't have to tell you that the enormity of the mental health problems in this country, as Alan Kazin has written about recently, would never allow us to see one-on-one everybody who needs, even if we increased our workforce by 10 times. We'd never be able to see that. So obviously we have to look for these other kinds of public health solutions. This is something we've said recently. Obviously, we can't integrate everything we do into primary care settings. There's always going to be a need for specialty practice. And how can this specialty practice best be implemented? Once again, I think we look to telehealth. The internet-delivered treatment, much as with the previous example, can help us really expand our care, psychological treatments, to families who would otherwise not take advantage of it. This initial effort I'm showing you is from our center. Jonathan Comer was the prime mover. And he was working with families with oppositional difficult children using PCIT, parent-child interaction therapy. So from Boston University, we were able to reach various distant parts of our state, and yes, we do have some rural parts to Massachusetts, and do the kind of study for PCIT, which with Skype now, which was this particular technology, very easy to really set it up, see exactly what the interactions are, what's going on. Relationships, alliances seem to build. And so the preliminary results from that effort also seem to be encouraging. And finally, another effort from our clinic has been to look at direct-to-consumer advertising. Now, circling back to what I said in the beginning, first of all, we need advocacy and more advocacy. But secondly, we also need to increase the awareness of the population about the services we have to offer. We'll never match the ability of Big Pharma, who could buy 10 Super Bowl ads and never miss the money. We'll never be able to do that. But as you know, APA has begun some efforts in this regard. And I think, it seems to me, we should be putting a lot more effort into this kind of activity. We have the information that consumers want. We know what we do works. We know what we do is cost effective and with fewer side effects. We have all that information. And obviously, if we can get the people to realize it. We did a randomized study. We did a study of consumer advertising where we went to Canada to do it because they don't have direct-to-consumer advertising. So we did it with our colleagues in Canada, even though they watch, Detroit. We did it in Toronto, so they watch the Detroit TV stations occasionally, but they're not accustomed to that. So we did some web-based placements and had people look at, one was the benefits of psychological treatment. The other was not only the benefits, but the disadvantages of drugs, side effects. And the third was drugs. And we began to look to see, did it change intent to seek treatment? And there was no question. These ads changed intent to seek treatment. Interestingly, the one showing the drug side effects was more effective. So we might have to engage in some negative advertising. But anyway, I think we need more information along these lines. I think, honestly, that there are some very encouraging trends. We have a lot to offer. It's really a question of informing not only the policymakers, but the public of what we have to offer, of getting the word out there. And obviously, nobody's in a better position to do that than our practice directorate. If I could take 20 more seconds and just say, it's no secret to you that I'm approaching the end of my career. Or let's say I'm closer to the end than the beginning. That would be fair to say. And I'm really delighted to see, to hear about the young people here, the APAGS people, the people who are going to pick up the ball and carry it down the field. In the last few years, as Catherine noted, I devoted a lot of my time to our foundation, the American Psychological Foundation. We're undertaking a campaign now to transform the future of psychology by funding young psychologists in their research and their new practice modes and everything. It's a $5 million campaign, very modest by the standard of campaigns. We have 2 pages in the Monitor every month. I would really invite you, we've been gratified by the response we've had from leaders in psychology. I would really invite you to help ensure the future of psychology by joining us in this campaign, if I could. Sorry to steal that 30 seconds. Thank you very much for your attention.